Dr. Rajvardhan Narayan, Dr. Shamanta Das, and Dr. Nilofer Rahman. They will speak on the topic out of the closet challenges of the LGBT in the clinic and the community. I would like to call upon stage our Honorable Chairperson, Dr. Rajni Gupta, to chair this session. Mic is the
Good morning, all. Let's begin with the first session for the day. Uh, I think it's very important for us to include the other community also, which needs some kind of acceptance and respect in the society. So we'll begin with Dr. Nilofer. Yeah.
Yeah, 15 to 18 minutes. Yeah, I hope so. Okay, I hope I'll finish within 15 minutes. Okay. Yeah. Good morning, respected chairperson and honorable delegates present here. So I am Dr. Nilofer Rahman. I am pursuing my post-graduation training in Guwahati Medical College, Assam. So yeah, today is quite an interesting topic, that is LGBT. I'll be just discussing an overview about LGBT. So what is LGBT? LGBT is the abbreviation that is used for different words like lesbian, gay, bisexual, transgender, transsexual, and many more, like two spirits, intersex, queer, questioning, asexual, ally, pansexual, and many more. These are people who select those sexual or gender identity labels which are personally meaningful for them. LGBT is the replacement of the term gay community, which did not represent the whole community and hence replaced. There are different cultures, and in different cultures, there are different norms. In some cultures, there are two genders, like male and female, while in some other cultures, there are three genders or more, like male, female, bardags, two spirits that is usually believed in by the Native Americans, hijras in South Asian subcontinents, zeniths, etc. Before knowing about LGBT, we should have a clear knowledge about the difference between sex and gender. So sex is something that is biological. It refers to the physical, physiological, biological differences between males, females, and intersex. While gender is something that is the social aspect. It is a person's social status as male, boy, man, or female, or an alternative category. Coming to the epidemiology, the prevalence reported for transgender in DSM-5 is 0.005 to 0.014 for birth-assigned males and 0.002 to 0.003 for birth-assigned females. In 2016, data from Center for Disease Control Behavioral Risk Factor Surveillance System suggested that 0.6% of US adults identify as transgenders. In India, overall meta-prevalence per 1 lakh population was 9.2 for surgical and hormonal gender affirmation therapy. There are no official demographics as of now for the LGBT population in India, but the government of India submitted figures to the Supreme Court in 2012, according to which there were about 2.5 million gay people recorded in India, which might be just the iceberg, the tip of the iceberg. So elaborating about the history of LGBT, let's start from Rig Veda. So in Rig Veda, it was mentioned there that Vikriti evam Prakriti, which means that which seems unusual is also natural. Was also mentioned about Varun and Mitra, the same-sex couple in Rig Veda who had also children together. Shikhandi, who was a character in the epic Mahabharata, was born as a female but brought up as a male, and daughter of Drupada, who fought by the side of Pandavas in the battlefield of Kurukshetra. This is the sculpture in the walls of Elephanta caves, depicting Ardhanariswara, the idol of Lord Shiva, depicting half of the body of Lord Shiva as female, the part of goddess Parvati, and half as male, which also gives an idea about hermaphrodism, that is the organ of two genders in the same body. Ayappan, also called Hariharaputra, is believed to be born from the union of Lord Shiva and Mohini, who was actually Lord Vishnu. And of course, in different walls of monuments in different parts of the country, there were lots of such sculptures which depicts homosexuality, as we can see in this picture. About the T in LGBT, that is the transgender part, it's an umbrella term usually referring to persons whose experience or expressed gender does not conform to normative social expectations based on the gender they were assigned at birth. Like a transgender is a person who may come to you and will say that I'm born in the wrong body. My body is not congruent with my soul. Yes. So this is something that is happening with the mind, with the brain. One more important thing in this is that when we can call a person a transgender, for that we'll have to understand what is gender affirmation. Say a person come to us, a client, and says that I feel incongruent with my body, and tomorrow he will come again and will say that, yeah, from today onwards, I will dress up like a woman, and I want others to address me as she. Then that is gender affirmation, and from that time onwards, we will also have to address the very person as madam or she, the exact pronouns we need to use. And that is gender affirmation, and that's how a person we need to address. Coming to transgender-related nosology, DSM-1 and DSM-2 didn't include any gender diagnosis, while ICD-9, there was inclusion of the term transsexualism. In DSM-3, under the parent heading of sexual deviation, there was gender identity disorder of childhood, which was kept. In DSM-4, again, the parent heading was changed to sexual and gender identity disorders, under which they were, again, included gender identity disorder of childhood, of adults and adolescents, and not otherwise specified. But yes, there was retention of the word disorder, perceiving as quite stigmatizing. So the DSM-5 changed the terminology of gender dysphoria and changed it to gender dysphoria and shifted the focus to dysphoria as the target symptom rather than the gender identity itself. And again, it is proposed in ICD-11 that the dysphoria will be taken up by the term incongruence, that is gender incongruence. And the second change, that is, it will most likely be moved out of the section of mental disorder and will be placed in another heading of sexual and gender health. So understanding transgender, it is like an umbrella, and it includes lots of other words or meanings under it, like, for example, transsexual. So these words are quite confusing and interrelated. Transsexuals are those transgender people who plans to or is undergoing kind of hormonal or reconstructive surgical procedures to be more congruent to their experienced gender. Yeah, then intersex persons. So these are the individuals with lack of concordance among various sex characteristics like sex chromosomes, gonads, external genitalia, so that question often arise as to which gender should be assigned at birth. So these things are quite different. Intersex people, their assigned gender at birth might be same as that of their experienced gender. Say, for example, a woman coming to our department, and she came with primary amenorrhea. And after lots of exhaustive investigations, it came out that her karyotype is XY. So this lady was brought up as a female, her assigned gender was also a female, and her experienced gender is also a female. And this kind of illness, intersex condition, these are actually mainly biological conditions with involvement of hormones or structural changes, abnormalities are there. And nowadays, the word intersex has been replaced by the term, preferably disorder of sexual development. And it includes conditions like congenital and adrenal hyperplasia, 5-alpha reductase deficiency, etc. Then again, we use the terms like male to female, female to male, MTF, FTM, this kind of words or short terms we use. So what are the symptoms of gender dysphoria? A person coming, the word as per se, transgender is not an illness or a disorder. When it is associated with distress, with lots of stress about the incongruency, then the term dysphoria come in the picture. So it includes, the symptoms includes like strong desire or belief self to be of the opposite sex, cross-dressing, engaging in stereotypical games, role play of the opposite sex, preference to have friends with opposite sex, refusal to wear stereotypical dress. Among adults, it can be belief of being born in the wrong body. This is one of the most common complaint with which a patient comes. I am born in the wrong body. And intense desire to change primary as well as secondary sexual characters. These are the diagnostic criteria, and the symptoms should remain at least for 6 months, consistently for 6 months among children as well as among adults. Okay, briefly about homosexuality. Who are homosexuals? People with same-sex attraction, both sexually as well as emotionally. Reason for same-sex attraction. The brains, for the basic, brains of a gay guy and a straight girl have very much similarity. It's by birth, neither by choice nor by upbringing. Many a times, many people come to us and ask that, can you cure homosexuality? Even our own colleagues from different departments like urology, endocrinology may come up. So the question at that time I'd like to ask is it a disease to be cured? No, it is just a diversity. It's just a diversity of the nature. As there were lots of research, and it was proved that homosexuality behavior is also exhibited among different animals, other than human beings as well. So the different lies about reparative therapy are there, and it might be quite harmful for an individual and his psyche. And in many places, things like reparative, forced rape, and all these things are carried out. So as a result of this, reparative therapy has been banned in California, New Jersey, Pennsylvania, Ohio, and in many other states. Now an important part, the factors influencing gender expression. Coming to the biological part, hormonal part, the effect of hormones in the human brain is maximum in 3 stages. That is the prenatal, pubertal, and in women, that is the first pregnancy. So during this prenatal stage, what happens is there might be androgenization of the brain, like in case of conditions like congenital adrenal hyperplasia. We can prove with this kind of conditions that there is subtle effect of these hormones in the brain during the prenatal state, especially in the first trimester of pregnancy. Now, anatomically, there is an area which shows gender variance. That is the bed nucleus of stria terminals, which is a part of limbic system, forebrain limbic system. So this part also shows difference between male and female. And this area of transsexual female is quite similar to straight female. Coming to fingerprint asymmetry, also there were lots of studies going on these things, like the women have more number of ridges on the left side, and overall there are more number of ridges in the hands of males. So this is also similar. Similarities are found between transsexual females and straight females and transsexual males, that is, earlier they were female, converted to male, and straight male. Coming to sibling order, yeah. It was also found in several studies that with increased order of male siblings, there is increased chance of a man or a boy showing androphilic behavior. Like we can see in this diagram, more number of elder brothers, and there is more chance of showing androphilia or attraction towards the same sex. It is because of progressive maternal immunization to male fetus through HY antigen in successive pregnancies and resulting in feminization of the baby in vitro, in vivo. Coming to genetic influence, lots of studies going on between increased number of increased maternal aunt to uncle ratio, which shows that there is increased chance of having a nephew who shows homosexual behavior. So this is not an autosomal simple Mendelian kind of inheritance. It indicates polygenic kind of inheritance involving X chromosome as well as chromosome 8. Coming to psychosocial factors like verbal labeling, psychosocial factor, which is kind of quite important and shows us the idea, gives us the idea about nature versus nurture. Like verbal labeling, calling a boy like Baba and calling a girl like with the names, with the pronouns. Non-verbal gender cueing, like gender role expectations. These are quite important stuffs. Excessive mother-to-son symbiosis, excessive skin-to-skin contact, these are also some of the things that, that increases the chances of homosexuality in future. Certain studies are only there about it, not proved. Social learning theories focus on differential reinforcement of sex-type behavior by parents. Yeah, now coming to differential diagnosis, like simple nonconformity of gender roles, body dysmorphic disorder, which is confusing at times. It may coexist with gender dysphoria, but it is not a contraindication for reassignment surgery. Transvestic disorder, gender-themed delusions, which are common among psychotic patients, intersex condition, I have already explained about it. Now, why LGBT health is important? There are two worlds for them. Basically, a world which is welcoming, quite supportive, but the other world which is full of stigmatization and stigmatization.
Can I request doctor to complete, because the time's up.
Yeah. So with lots of acceptance, there are lots of discrepancies also, lots of suicides going on in different parts of the country, in India itself, as we can see. This attempt of suicide is 8 times more common among LGBT groups, that is around 47%. They more commonly suffer from depression, drug use, and other conditions. Youth is a very crucial period, and homophobia is quite common in Indian schools, which is an unaddressed problem. And as a result of this group of individuals requires support. They are pulled off often with mere suspension and triggered by the body language, etc. And also, it should be kept in mind that those children who fulfill the DSM-4 criteria for gender dysphoria in their childhood or adolescence, they get desisted later on. That means they no more fulfill the criteria of gender dysphoria later in life. So this adolescence is we all know that adolescence is a period of experimentation. So it usually also happens, it's a part of the normal development. This is about the gay and lesbian right. The red parts, in these countries, death sentence is given to those people who exhibit homosexuality or same-sex relationship, and green are those which are quite acceptable. India is the yellow part where it is decriminalized, but there is no proper law or legislation till now for this, for LGBT care and health. About the tolerance, here we can see India is white, which is least tolerated. About homophobia, we all know it is about the negative attitude towards LGBT people. Coming out, which is very important, and it is maybe quite liberating as well as difficult, and mostly it happens during the adolescence, which is again a crucial period, and at that time, these people needs a lot of support and seek family care as well.
Dr. Saab, can I request you to wind up in next 60 seconds, please?
Yeah, yeah. So yes, World Professional Association for Transgender Health, WPATH, which is an association which promote evidence-based care, education, research, advocacy, public policy, and respect among transgender health. So under this WPATH, there are lots of terms and criteria with which we can treat and manage the patients coming to us with with LGBT issues, transgender health issues. So be an ally. It is very important to amalgamate into them. Ally is something which comes under LGBTIQA. A means ally. So by mixing up or mingling up with them, we can offer them a buddy system, which also helps to improve the rapport and provide support and know the issue, exact issue. So yeah, again, social acceptance, most importantly from the family. So family support and family therapy is also important. So lastly, imagine a world where being gay, the norm, and being straight would be a minority. So support LGBT because it's not a choice. With that, I would like to end. Thank you.
Thank you, Dr. Saab. That was a wonderful presentation. I request the second speaker, Dr. Rajvardhan, to please come.
Good morning, respected Chairperson Madam and esteemed guest here. I am actually a proxy presenter for Dr. Mathili Hazarika Madam, who happens to be my teacher also. I will be discussing in very brief, actually a case series of 3 cases related to gender dysphoria. Three cases, one by one, I will be discussing. First of gender dysphoria, another one of ambiguous genitalia leading to gender dysphoria, and third one is a relatively rare condition with ovotesticular disorder of sexual development, which was previously also known as the true hermaphroditism. Coming to case, first case, from being female to being male, which was not achieved in a day. A patient AB was referred from a private hospital in Delhi for psychodiagnostic evaluation and therapy in 2010, who wished for sex reassignment surgery. 6 months later, 6 months, over a duration of 6 months, he underwent session as well as evaluation, which revealed that she was having gender dysphoria with dull normal IQ. She fulfilled the criteria, so she was referred to the team of sex reassignment surgery. Here we must, Dr. Nilofer also has just mentioned that the management of transsexual is guided by Harry Benjamin International Gender Dysphoria Association's standard of care, and this association is also now known as World Professional Association for Transgender Health, or WPATH. Coming to the therapy session of first case, about the background, there was a history of very disturbed childhood due to poverty, but from very early childhood, she had a strong desire to be a boy and felt trapped in a girl's body. During adolescence, she met her current partner, who happens to be a girl, with whom from a very early age she developed a deep and intense bond. Desire to become a complete man got reinforced with her company. And the strengths of her personality were resilient, very optimistic, self-reliant, and determined. Coming to the psychotherapeutic interventions taken for that case, initially the therapy session focused on a desire to become a man. We have to check it out whether it was induced or not. Later it came out to be not to be induced, it was spontaneous, and challenging her status with an active stance. When gender dysphoria was established with tests and interviews, then work for her to get adjusted to the new role of a man with attire and social activities began. For first 1 to 2 years, sessions were once a month, but later on, subsequent sessions were planned after surgeries every time, and supportive work even continues now also. And this is very important slide. Here, there are, when the mental health professional is a case planned for sex reassignment surgery, if it is mandatory before surgery and after surgery, the patient must attend the counseling session and psychodiagnostic evaluation. So when we are sending our report to the sex reassignment surgery team, so we must include these parameters like the identifying characteristics, initial and evolving gender, sexual and other psychiatric diagnosis, duration of professional relationship with the patient, number of consults, the type of psychotherapy or evaluation that the patient underwent, specifying the eligibility criteria that have been met, and the rationale for prescribing hormone therapy or surgery, along with degree to which the patient has followed the standard of care till time of writing and the likelihood of future compliance, whether the mental health professional is part of a gender team. And this slide shows that very patient, when she went in a private hospital in Kolkata only, she underwent the sex reassignment surgery, and after the surgery, this certificate was issued by the surgical team, and it clearly mentioned that she can now be officially addressed as male. The doctor gathered she has changed her name to so-and-so, and from medical point of view, he is a male. Coming to the challenges and legal issues in sex reassignment surgery. First and foremost, the access to specific health care needs denied, and stigma is very high in our society. Many transgenders would like to undergo hormonal therapy and sex reassignment surgery. Unfortunately, they are denied these services in majority of hospitals, including public hospital. This sex reassignment surgery, if done also, operations are done by untrained local people in an unhygienic condition. And those who are practicing, they are unaware of the Harry Benjamin standard of care for sex reassignment surgery. So those protocols are not followed. And an urgent need to standardize sex reassignment surgery guidelines for Indian transgender community, and to make whole process of SRS services available, affordable, and accessible in public hospital. Coming to some of the legal challenges that these people face. The transgender person faces discrimination from all sphere of life and is stigmatized from womb to tomb. And as all of us know, that Supreme Court, in his verdict on September 6, 2018, decriminalized the Section 377, which is a very positive step. In our case also, this lady, which then changed to male gender, he was denied name change in legal document after surgery and faced a lot of trouble. And we had to do liaising with advocates for her legal work done. And it took a lot of time. To provide protection of right to transgender person, the Government of India has passed a legislation called the Transgender Person Act 2019, which received action from the President on 5th, very recently, 5th December 2019. And this is very important piece of legislation, Transgender Person Act 2019. Few important salient feature I will discuss. There is provision to set up separate human immunodeficiency virus serosurveillance centers to conduct serosurveillance for such persons in accordance with the guidelines issued by the National AIDS Control Organization. There is also provision to provide for medical care facility, including sex reassignment surgery and hormonal therapy. Before and after sex reassignment surgery and hormonal therapy, counseling services should be provided to bring out a health manual related to sex reassignment surgery in accordance with the World Profession Association for Transgender Health Guidelines. And there is also provision for review of medical curriculum and research for doctors to address their specific health issues, because it is a very sad that majority of even those who are working in field of psychiatry and mental health, majority of them are not aware of these guidelines and how to deal with these patients. To facilitate access to transgender person in hospital and other healthcare institutions and centers, And lastly, provision for coverage of medical expenses by a comprehensive insurance scheme for sex reassignment surgery, hormonal therapy, laser therapy, and other health issues of transgender person. Coming to the certification part, certification of identity. Under Section 5 of this very Act, transgender person may take an application to the district magistrate for issuing a certificate of identity as a transgender person. And the role of medical fraternity has been removed for the purpose of gender identification. Coming to certification of gender change, we'll have to submit the gender identification certificate along with medical certificate issued by the medical superintendent or chief medical officer of the medical institution where the sex reassignment surgery has been conducted. And with these two prerequisites, she can apply to the district magistrate for certificate of gender change and name change in all official documents, including birth certificate, under Section 7 of this Transgender Person Act. And what are the important drawbacks of Transgender Person Act? It is silent about the burning issues such as marriage of transgender person, adoption of child by transgender person, right to social security and pensions. This very patient also, after the sex reassignment surgery, she was very willing to adopt a child and marry, but as of now, these worries, there is no solution to that. The legislation makes half-hearted attempts to provide right, but no proactive measure have been taken to ensure the economic, social, and cultural rights of transgender persons. It is silent about the budgetary provisions to make the rights available to every transgender person. It does not proactively discusses the hormone therapy and sex reassignment surgery as a right, and it does not classify or determine what constitutes the sex reassignment surgery. This Act mandates SRS for gender and name change in all documents and to be certified by district magistrate. Coming to the second case, it is a case of patient with ambiguous genitalia at birth that led to confusion in gender identity. And problem started very early in life. And since birth, there was a maldeveloped lower abdominal wall with abnormal fleshy mass and at the lower part of the abdomen. Continuous urine leak was there from that mass. Maldeveloped ambiguous genitalia was there since birth. And it was a 17-year-old unmarried person. And for last 6 to 7 years, he was complaining of some depressive symptoms also, like feeling of sadness, worthlessness. Client's mother had 5 girl children before. So mother strongly wanted a male child at that point of time. And on delivery, family member noticed that the baby has deficient lower abdominal wall with no proper sex organ enough to label the child either male or female. So they were confused and assigned, the gender assigned at birth was male. Gender role and identity was male, although he could not actively participate in play. He preferred to play with boys. One reason was that there was a constant leaking of urine also. And thalarchy started at 11 to 12 years of age. Patient was referred from local surgeon to our setup, Guwahati Medical College, and was admitted in Department of Endocrinology, from which he was referred to Urology Department. This picture is showing habitus was feminine, high-pitched voice, no beard growth, scanty axillary hair, breast nodule was there, deficient lower abdominal wall you can see. Then labia majora, labial fold were present, minora was also present, clitoris was absent. On investigation, genetically, she was a female. And diagnosis was extrophy in CT, extrophy of bladder with ambiguous genitalia. This picture, peer group was mostly boys. Some depressive symptoms were there on mental status examination. And coming to the session, I will be as brief as possible. The stress diathesis model was planned. Supportive psychotherapy, cognitive behavioral therapy approach, and family psychoeducation were undertaken. Outcome was very satisfactory. Client depression reduced from severe depression to moderate. Gender identity confusion got diffused. Client confirmed that he wants to live as a male and wants reconstructive surgery with acceptance of the disabilities. Case was referred to higher center for surgical needful. Coming to case 3, it is a case of over-testicular disorder of sexual development, which is a very rare disorder, as rare as 1 in 20,000 cases. Gonads can be any combination of ovary, testis, or combined ovary and testis. And the external genitalia are usually ambiguous. This patient was presented at 24 years of age. Abnormal urethral opening was there, empty scrotal sac, and since birth. And there was undesired enlargement of breast, starting at 7 to 8 years. And for last 6 to 7 years, there were some depressive symptoms also. At 4 months of his age, he had undergone a corrective surgery also. On examination, there was male voice, no beard growth, with acne, scanty axillary hair, breast development seen externally, perineum was normal, external genitalia was like a male. So both male and female, because it was a true hermaphrodite. So both some male and some female features were there. On psychological evaluation, depression was noted secondary to gender identity issues. He was assigned male status since birth. His gender identity was male and had male external genitalia. Sexual fantasies is towards female, and he wished to be a male always. He had to wear tight and thick undergarment to hide his breast size. Psychotherapy sessions were taken, and on catharsis, his utmost desire to become a male was found out. He had prominent depressive and anxiety symptoms. And a strong death wish was also there. Being a male with enlarged breast was a significant stressor for him. The team recommended, considering his gender identity and sexual orientation with a strong death wish, it was highly recommended for him to undergo surgery and other treatment for genital anomalies and identity diffusion. I will conclude. Very often this transgender population is not allowed inside hospital. Health insurance excludes them, and high risk for various physical illnesses, mental illnesses, and suicide rate. There is an urgent need to sensitize the community about the transgender person's right education regarding homophobia and health needs, as the healthcare professional and the gatekeepers have very poor knowledge. Thank you.
Thank you, Dr. Sir. We request our third speaker, Dr. Shamanta from Guwahati, to please come.
This one, yeah, this one. Respected Chairperson, my co-speakers and esteemed audience, we arrive at a part 3 of this symposium, Out of the Closet, Challenges of the LGBT in Clinics and Community. My name is Shamanta Das, Editor-in-Chief, Open Journal of Psychiatry and Allied Sciences, Assistant Professor, Department of Psychiatry, Guwahati Medical College Hospital. To begin with, come February 21, and we see the release of Shubh Mangal Zyada Sabdhan, a film on a gay man who is in relation with his neighbor, starring Ayushmann Khurrana. I'd like to quote Ayushmann Khurrana. I was born and brought up in a small city, and growing up, I did not have adequate knowledge, understanding on this. I have seen my perspective about the LGBTQ community evolve, and I slowly recognized the societal stigma and stereotypes associated with the community at large, and it pained me, unquote. Same was the story this side as well, until and unless we come across this individual. Milin from Guwahati lives in Minneapolis, Minnesota. We came to know that it is not simply a 4-letter word. Instead, there are many more letters into it. We held a discussion at Guwahati Medical College Hospital. It was an organized and formal discussion, never occurred before there. Organized in the way that not only mental health professionals like psychiatrists, psychologists, and psychiatric social workers presented their perspective on the subject, but also our colleagues from different disciplines in medical science, including neurologists, endocrinologists, and plastic surgeons, also presented their perspectives. Moreover, 2 transgenders, female to male, through sex reaffirmation surgery, shared their journeys in that platform. There were participation by LGBTQ activists, and there was a huge participation from students, both medical and nursing stream. Subsequently, we had a Zoom meeting with Troy R. Weber-Brown, who is a sexual and gender medicine therapist and running support systems for this community at Minneapolis. We all know that the world is a global village. With a click of a mouse, we can appraise ourselves about the worldwide developments. And it is pertinent too to keep ourselves vibrant so that we know what's happening around. But while applying a globally acceptable approach to our population, it is pertinent that we take into account the cultural and geographical issues. And once such a modified approach becomes successful, it again needs reapplication, in fact replication, to have a wider acceptance. This global-local two-way approach led a school of thought to coin a new terminology, glocalization. Keeping glocalization in mind, we started LGBT support group in Guwahati, consisting of 8 weekly sessions in collaboration with another organization called Hukia, who is working on the LGBTIQ discourse in India's northeast part. The support group is still continued, which starts with the participants introducing by their name, then their preferred pronoun, followed by affirmation and the agenda. One of such support group took place in Petio, a restaurant owned by one of our active members, Shankar Chaudhary. And I'm proud to share that it is the only LGBTQI-friendly restaurant in India, noted so in both Zomato and Swiggy. Jack Black in Goosebumps says, every story has a beginning that we discussed, middle part that also we discussed, and the twist. The World Bank has recognized that there are 31 low-income countries, 53 lower middle-income countries, 56 upper middle-income countries, and all rest are high-income countries. Countries belonging to one particular group show multiple diversities. Still, the terminology of low and middle-income countries, in short, LEMIC, is an acceptable nomenclature. If we take India as a prototype of LEMIC, we see the huge patient population, at the same time, lack of professionals. This results into a big gap among service users and service providers. Agreed, patients do suffer because of this gap. But at the same time, the healthcare professionals gather tremendous experience and expertise as a result of this. Of course, time is a constraint in such a busy clinical setup. But even then, if we try to extrapolate this experience and expertise in research activities, the lack of it strikes out. This interesting piece of work looked into the indexation of psychiatric journals in major bibliographic databases like the PubMed or Medline and Web of Science, earlier run by Thomson Reuters, now Clarivate Analytics. What they found that out of the 222 indexed journals, 213 are published from high-income countries and only 9 for upper middle-income countries and none from low-income countries. Denoted by this 595 gap causes problem because 80% of the world population lives in LEMIC. Quite obvious that the highest burden is carried by these countries. But research carried out in these areas doesn't get proper representation in world literature because of lack of a LEMIC-focused journal that is published from LEMIC. Subsequently, there were initiatives to promote journals. Those are published from LEMIC. Our own Indian Journal of Psychiatry is an example of that, which is now indexed both in PubMed as well as Web of Science. This was an initiative at the leadership of Mario Maz, the president of World Psychiatry, which is the highest impact factor psychiatry journal. And it is published from Milan, Italy, a high-income country. Another such initiative is the Global Mental Health. It is a publication of Cambridge University Press, another high-income country. So most of these initiatives for LEMIC journals are from high-income countries. So our weight was for a LEMIC-focused journal published from LEMIC. The Society for Mental Health in LEMIC, in short, SOMHIL, was formed to promote behavioral science in low and middle-income countries. The two half circles in the globe represents the high-income countries and the LEMIC respectively. And through brain literature, the aim is to bring these two regions of the globe at par. Maithili Hazarika, Bornali Das, and Otono Borua are the president, secretary, and convener of SOMHIL. In collaboration with Academy Publisher, on behalf of Academia Dysphrenia, a journal is published, namely Open Journal of Psychiatry and Allied Sciences. And it has completed a decade of publication. OZEPAS is publishing works on the subject. It is an open access journal. Those interested can easily access them. Some of them are case study on intrapsychic disarray of gender identity and sexual orientation in the process of coming out as transsexual by Bodhisattva Shankar Das and Soumitra Ghosh from Dibrugarh, Assam. Original research article on self-reported sexual orientation, relationships pattern, social connectedness, disclosure, and self-esteem in Indian men who use online gay dating website from Gangtok, Sikkim. Research article on a study of high-risk behavior among LGBT people of Manipur, a northeast India state. Case study on disclosure of sexual orientation, case series depicting parental response, again from Dibrugarh, Assam. Case report titled, I am no male or female or any other, I have no sex. A case report on asexuality from Imphal, Rims, Manipur. Original research article on a study on perceived parenting style among transgender from Ferry, Kolkata. Review article, practice of family therapy in a heteronormative society of India from queer theory perspective. It was a review article. And a commentary on homosexuality, how therapists can help. To enrich our endeavor on this subject, now we have as convener, I'm sorry for indistinguished letter, of IPS LGBT Task Force, one of our colleagues from Guwahati, Annesak Das, who is the convener of this task force. And to conclude, currently we are undertaking a work on attitude towards and knowledge about lesbian, gay, bisexual, and transgender, LGBT among medical doctors, medical interns, and nursing professionals, an observational study carried out at Guwahati Medical College Hospital. Results till now show that 80% of the participants are showing a positive attitude. With this positive note, thank you.
I thank all the three speakers for the wonderful presentation, talking about history to case histories and the future aspect. Thank you very much. Since it's symposium, I don't think, can we take any questions? We have 5 minutes if the audiences have any questions. Done? Okay, thank you.
I would like to request our chairperson to honor our speakers, please. I would like to request all the three speakers to honor our chairperson, please. Unfortunately, our session from 9 to 10 got cancelled. So if anybody wants to move to the another hall, they can move to the another hall for other sessions, please. And the next session will start from 10 o'clock on the topic of SLD, and the speakers are Dr. Alka Subramaniam, Dr. Henal Shah, and Dr. Shubhrata KS. From 9 to 10 in Hall 2, Stress Among Doctor. Session is already going on in the Hall 2. In Hall 3, Smart Psychiatry Concept, Current Status and the Applications. In Hall 4, Internet Addiction. In Hall 5, Comprehensive Management of the Neuropsychiatry Aspects of HIV and AIDS. In Hall 6, Rape and Social Evil. The session is already going on. If anybody wants to attend that session, they can move And the next session will start in Hall 1 from 10 o'clock on the topic of SLD.